Hello everybody, welcome to MSA New Jersey's first conference for MSA patients and caregivers. Thank you all for joining us today. We recognize that everyone is at different stages of the disease and that the disease presents differently. So our goal is to provide an overview and have the opportunity for you to ask questions, including those of you joining us online, so that you can get the most out of this session. We hope that you will. We're going to begin the session this morning with our medical presentations, and I will introduce Dr. Colcher and Dr. Curlin in a moment. After they've both presented, then we will open the floor to questions and answers. Okay? So you've gotten out some notes of some things that you might want to ask. You have their PowerPoints in your folders. Then we have a series of presentations from wonderful physical therapists, hospice care, caregivers, and so forth, and a special pre-recorded message from Dr. Dorothy Kaufman. So we've got a full schedule ahead. I want to thank everyone for coming. I want to thank all of the speakers and participants, including those that have set up tables for us. There's a lot of interesting information about speech and swallowing and new progress in urinary issues, hospice care, a lot of miscellaneous information, so do take the time to look everything over and meet with them as well, please. So let's go ahead and jump into the medical presentations. I'm going to introduce both physicians so that when Dr. Colcher is finished, Dr. Curlin can jump right in. Dr. Amy Colcher, Director of Movement Disorders Division and Professor of Neurology at Cooper University Health System in Camden, New Jersey. She teaches at Cooper Medical Center of Rowan, conducts clinical research in movement disorders, and has participated in trials on Parkinson's disease, MSA, Huntington's disease, dystonia, and essential tremor. She worked at the University of Pennsylvania from 1997 to 2012, and did her neurology training at Georgetown University and movement disorder fellowship at the University of Pennsylvania. And I'm going to add to her bio that we crossed paths in 2012 when she was transitioning from University of Pennsylvania Hospital to Cooper. That's when she participated in the national conference that we hosted here in New Jersey. And then shortly thereafter, graciously agreed to serve on our board. So she's also a member of the MSA and J Board of Directors. And Dr. Roger Curlin. Dr. Curlin obtained his bachelor's degree from the University of Rochester in 1974 and his medical degree from Washington University School of Medicine in St. Louis in 1978. He did a residency in internal medicine at Washington University and then a residency in neurology and a fellowship in movement disorders and clinical neuropharmacology at the University of Rochester Medical Center. He remained a faculty member at the University of Rochester from 1984 to 2009, so we've been doing this a while, serving as professor of neurology and Center for Developmental and Aging Neurobiology. He's published more than 250 articles and edited 3 books. He's recognized internationally for his clinical and research expertise in neurological movement disorders. He's got a record of steady federal support for his research. His investigations have focused on experimental therapies, but he has published extensively on epidemiology, genetics, cognitive and behavioral aspects, and neurobiology. He has long-standing collaborations with basic neuroscientists and conducted many large-scale, multi-center clinical and translational research studies. He's a founding member of the Parkinson's Study Group and founding and current leader of the Tourette Syndrome Study Group. Dr. Curlin moved to Atlantic Neuroscience Institute at Overlook Hospital and Summit in November 2009 to direct movement disorders program, where he continues his clinical care and research. And I will add here that we crossed paths about 2 years ago, roughly, when one of our group's patients connected us to Overlook and then to Dr. Curlin, and that's where we hold our monthly support group meetings. And Dr. Curlin has come to visit and has helped to get the word out to patients, and especially about the conference. And we're happy to have both esteemed physicians with us today. So I am going to turn the floor over to Dr. Colcher.
my talk is more about the clinical aspects and diagnosis of MSA, and most of the people in this room are very familiar with it already. So I don't want to act like I'm telling you stuff that you already know, but hopefully there'll be something in here that you didn't know already. And I was sort of listening as I was grabbing some coffee to some other people talking about how family members get diagnosed with this disorder. And because I am a sort of a movement disorder specialist, I am not typically the first doctor that patients see. So, you have some advantage in the fact that symptoms have been going on for a while before people come to me, and then I can look at the big picture. I can look at the whole history of their illness and their symptoms, and I can say, well, obviously you have this and not that, because there is so much time elapsing and there have been other things tried. So it is, satisfying to have an answer by putting all the symptoms together, but sometimes in the beginning of this disease, it's very easy to get it confused with other things. You don't know for sure what's going to happen over time or how things are going to develop, and part of that development of symptoms is what allows us to make a diagnosis. So that being said, let's next slide, sort of start with the general and get a little more specific as we go on. So multisystem atrophy is a combination of autonomic dysfunction and either Parkinsonism, symptoms like Parkinson's disease, or symptoms of cerebellar dysfunction. The cerebellum is the back part of your brain. It's the part of your brain that controls your coordination and coordination of movements involving your hands, involving your speaking, involving your swallowing. So coordinated movement sort of all across the board. Pyramidal signs means that you can have increased muscle tone and changes in your reflexes that go along with it. So some people come to the doctor and they're initially told they have Parkinson's disease because they have slowness and stiffness and trouble moving. Some people are told that they have ataxia because they have trouble with their balance and trouble with their coordination. Some people can be told that if they just have the autonomic symptoms, they may have trouble with their blood pressure, they may be passing out, they may be told that they have autonomic failure. These disorders used to be named differently, and now we sort of group them all into this big pile of diseases that we call multiple system atrophy. So we classify it clinically based on the symptoms that the person has as multisystem atrophy type C, which is the cerebellar type, where primarily the dysfunction is in the coordination system, or multiple system atrophy type P, which is the Parkinson's type, where people have more stiffness and slowness and look more like they have Parkinson's disease. Do the next slide. It is classified as a synucleinopathy. So what we use, when I felt a little old when you were sort of giving our bios there, but when I was a little neurologist, we used to classify diseases as Parkinson's disease and Parkinson's plus. And so you either had typical Parkinson's disease, which responded nicely to Parkinson's medicine, or you had Parkinson's plus something else. You had Parkinson's plus problems with your autonomic nervous system. You had Parkinsonism with some dementia and hallucinations. You had Parkinsonism and some eye movement abnormalities and frequent falling and all these other symptoms or syndromes that had something that looked like Parkinson's disease plus a little bit more and didn't respond as well to typical Parkinson's medicines. We call them Parkinson's plus syndromes. And we knew that those were a faster progression, and we knew that those things were not as easy to manage as regular garden variety Parkinson's disease. But as time has gone on and scientists have gotten more good at detecting what actually goes wrong in the brain with a lot of different disorders, there is a whole new classification of diseases based on protein abnormalities in the brain. And so multiple system atrophy, just like Parkinson's disease, is classified as what is called a synucleinopathy. And alpha-synuclein is a protein in the brain. You can do the next slide. Or let me go back one second. So the diseases that are classified as synucleinopathies are Parkinson's disease, regular ordinary Parkinson's, multiple system atrophy, primary autonomic failure, which is just where your autonomic nervous system doesn't work so well, and Lewy body dementia, which is a combination of Parkinsonism and hallucinations and memory problems. Some of those other Parkinson's plus syndromes that we used to just group in the same group with these other synucleinopathies, things like progressive supranuclear palsy, there's a different protein abnormality, so we don't put them in that same category anymore. So these are the ones that have a problem with alpha-synuclein. Okay, next slide. And so what does alpha-synuclein do? That is a very good question. And if I could answer that better than this, I would do that for you. It is a protein that is in nerve cells, and it seems to be localized to the end of the nerve cell, where the chemical that transmits signals between nerve cells is released. And so one thought is that it may modulate neurotransmitter release. So it may have something to do with problems with the signaling between one cell and the next cell. But somehow alpha-synuclein in diseases like multiple system atrophy, like Parkinson's disease, it's not made the way it's supposed to be made. And so it clumps up in the cell, and it can cause problems with a lot of the functions that need to go on in the cell. One of those functions is the way the mitochondria work. The mitochondria are the energy producers in the cell, so they make the energy for the cell and allow the cell to function properly. There is also sort of a garbage system in each cell. So when proteins have problems with them, when things get damaged, they get cleared out of the cell so that they don't gunk up all the machinery in the cell. And alpha-synuclein may have something to do with that, but when it aggregates, when it gets all clumped up in there, it interferes with the garbage removal mechanism. So you imagine if the garbage collectors didn't come to your house and you kept making the same amount of garbage that you do every week, eventually your house would get all stinky and you wouldn't want to live there and you wouldn't want to work there anymore. That's what happens in your cells when there's a problem with alpha-synuclein. So it's probably not just one thing that it does that makes the cells not work so well. And we don't really understand completely what it is that happens and how this happens in multiple system atrophy. But the good news is that now targeting these proteins and knowing where the protein abnormality is may help us in the future at targeting therapies more specifically toward individual diseases, because you know what you're going after rather than you're just going after a bunch of symptoms. Like this has some features of Parkinson's, so let's treat it like Parkinson's disease is very non-specific and doesn't, as we know just from time, that doesn't work so well. So we have to be a little bit more specific in targeting our therapy if we're going to want to slow down the progression of the disease or reverse the symptoms of the disease. Next slide. Okay, so who gets multiple system atrophy? It's definitely not as common as Parkinson's disease. It is a much more rapid progression than Parkinson's disease. It seems that men and women are about equally affected, and people can live a very long time with this disease. You quote survival rates from different studies that you look at, from diagnosis to when people die of this disease, can be very, very variable. And I have to say, in my own practice, that what I read and what I see are two completely different things. That most of the patients that I see live much longer than the statistics would bear out. And I think that is because we now have a better understanding of what to do to keep some of the symptoms at bay, to keep people active much longer. So I encourage you to pay attention to, especially this afternoon, physical therapists, speech therapists, as much as you can learn about how to keep moving, keep yourself safe, keep things, keep doing what you want to do for as long as possible. And so being more proactive in terms of other things like physical therapy, social activities, other activities to keep your life challenging and exciting is much better than doing nothing. So I think that our whole approach to these neurodegenerative diseases has changed over time, and that's what makes people live longer and live better with a disease that, even though right now we say that we don't have a cure for it, you can certainly have a good amount of time where you are still functional and doing well. Next slide. So we'll start with the autonomic dysfunction, because this is the thing that really helps you to make a diagnosis. It's hard to make a diagnosis of multiple system atrophy if a patient doesn't have any problems with their autonomic nervous system. And the most common issue that patients face is problems with their blood pressure, what's called orthostatic hypotension. Orthostatic is when you stand up, and hypotension is when your blood pressure goes down, so low blood pressure. So typically people will notice that they feel dizzy or lightheaded when they get up from sitting down, when they sit up from lying down, when they're changing positions so that they're getting up. And there are specific amounts of blood pressure change that we use to make a diagnosis of orthostatic hypotension, but most people will complain of symptoms. Other autonomic issues are problems with your urinary system, which I know you guys have a lot of questions about. Most commonly in men, we see erectile dysfunction, which over time almost invariably occurs in everybody who has this. And the urinary symptoms can be very varied. We'll talk about them a little bit more in the future in this talk, but you can have problems with the sphincter, where at the end of the bladder there's a little muscle there that contracts to keep everything in your bladder until you decide that you actually want to go to the bathroom, and then it relaxes and opens up that tube so that the urine can come out. Sometimes that sphincter is too weak, sometimes that sphincter is too strong, and it won't open when you want it to, so people end up retaining urine. Sometimes people have to go to the bathroom more often. Sometimes they go when they don't want to. They have a sense of urgency that when they have to go right then, and if they are not at the toilet, then they would go anywhere. There is also problems with the GI tract, with your gastrointestinal tract. Constipation is very, very common, especially in the patients that have the Parkinsonian type of multiple system atrophy, because everything moves slowly in those patients. And so the food, once you swallow it and it has to come out the other end, the slower it moves, the more time your GI tract has to absorb all the water out of there. So then what comes out the other end is really hard and really difficult to push out, and patients complain of constipation. They may also complain of trouble swallowing, so trouble sort of at both ends, from the incoordination of the muscles involved in swallowing, which get their signals from the brain, and if the brain isn't working right, then that can cause problems with swallowing as well. Next. The orthostatic hypotension, obviously most people do not have a blood pressure cuff at their house where they're checking their blood pressure to see if it's dropping when they stand up. So what they really complain of are symptoms of lightheadedness or dizziness. Sometimes they'll pass out. And so that's frequently why we advise people to stand up slowly and just stay where you are until you don't feel dizzy anymore, and then start walking. Because if you stand up quick and you walk really far away from your chair and then you feel dizzy like you're going to pass out, when you pass out you end up on the floor, whereas if you just stood where you were and you feel like you're going to pass out, you can pass out back on the couch or the chair that you were just sitting on. Some people will feel that their vision gets dim when their blood pressure drops. Other patients will complain of shoulder pain, neck pain, head pain. You may feel like your thinking is not as clear. You may feel weak all over, not one side or the other, but sort of a diffuse weakness or tiredness. Some people yawn when their blood pressure is too low, and some people find that their speech isn't clear. So all of these things can be symptoms of low blood pressure, and so it's not everybody that describes it sort of like a textbook in what can happen. Some of these other symptoms are symptoms of that and would give your doctor a clue that maybe your blood pressure was getting too low at some points during the day if you had these symptoms. Next slide. So a lot of people with multiple system atrophy will have these drops in their blood pressure when they change position, and that's because the sensors that regulate blood pressure in the body are damaged. They're not working right in multiple system atrophy. And the issue is, when we talk about treatment a little bit later, is that the response to medication is not always normal. Because the receptors are not working quite right, they may not respond to medicine that you want the way that you expect them to. So medicines, if you're on blood pressure medicine because you had high blood pressure before, it may drop your blood pressure way more than you expected to. Maybe you need it because you have other heart issues or heart rhythm problems, and you may find that that's making things much worse than it ever did before. Also, medicines that we use sometimes to raise the blood pressure may raise the blood pressure too much. I have a lot of patients that, we send them for physical therapy, and then the physical therapist won't do physical therapy because they checked their blood pressure before and it was too high. I'm trying to get their blood pressure high enough that they could stand up and do the physical therapy, but then the physical therapist is too nervous because it's too high. So it can be a little tricky when you're trying to manage this. But the idea behind orthostatic hypotension is that you're typically, if you were dehydrated and your blood pressure is going to drop when you stand up, when you stand up and your blood pressure starts to drop, your heart rate starts to go faster. So you should be, it's a reflex that is not under your control that compensates for the fact that you're a little dehydrated. So your heart beats faster to pump the blood up to your brain so that you don't feel dizzy and you don't pass out. But when your autonomic nervous system isn't working right, like in multiple system atrophy, your blood pressure drops and your heart rate doesn't change because that reflex is a problem. And so there's no way for you to compensate for the fact that your blood pressure is dropping because the heart rate increased reflex is not there anymore. And so that's how we tell the difference when somebody comes in and who's just passed out and we check their blood pressure in the office or in the emergency room. We check their blood pressure and their heart rate. And if their heart rate's going up and their blood pressure is going down, then we know that they're probably dehydrated and we need to give them some fluids. And if their heart rate is staying the same and their blood pressure is going down, then we suspect that there's something wrong with their autonomic nervous system. Next slide. Some people, it's not just when they stand up that their blood pressure will go down, but it's when they eat that their blood pressure will go down as well. So typically, again, when you eat, a lot of the blood rushes to your GI tract to help you get the nutrition and get the digesting of that food done. But if too much blood is rushing to your GI tract, then it's not available to be pumped up to your head, and you can feel lightheaded and dizzy as well. So it's important when people say that they feel dizzy that we find out exactly when does that happen. If it's happening a lot after you're eating, then maybe the best thing to do after you eat is to just sit for a little bit, just, watch TV, read a book. Don't go for a walk right after you had lunch, because that's when your blood pressure is going to be at its lowest. But wait an hour or two after you've eaten, so that you can manage that. Some people also have problems with their blood pressure when they lie down. So in addition to having your blood pressure be too low when you stand up, it may be too high when you lie down. And so sometimes it's a complication of the medicines that we use to treat the low blood pressure, but sometimes it's also part of the disease itself. So frequently we recommend that people don't lie flat when they have multiple system atrophy. They keep their head up a little bit so their blood pressure is not so high. Next slide. Other symptoms that this is sort of one of those things that as I was putting this presentation together, I think that this is something that we as neurologists don't talk about very much. That when you sort of give that overview and you give that diagnosis of you have multiple system atrophy, it's a combination of autonomic dysfunction and Parkinsonism or cerebellar dysfunction. We forget some of these other symptoms, and these can be very, very problematic. Problems with speaking. The voice of some people can get very hoarse, can get very high pitched. There is, the speech can be much more whispered than you would see in just regular Parkinson's disease. And you can also get what's called stridor, that the larynx, the vocal cords, that because it is so tight in there, the air doesn't flow the way it should. So people get this sort of high-pitched, almost wheezing sound when they're talking or when they're just breathing. And it can be so tight in there that they can't actually breathe well. And so this is something that to keep in mind, that if you start to hear some funny breathing or some funny breath sounds, that it may need some additional treatment. You may need somebody to look down there to make sure that the airflow is the way it can be, or the way it needs to be. Some people need to sort of bypass the larynx. The larynx is sort of in this part of your throat, and if the air can't flow easily up and down through that airway, then you may need to make another hole there so that the air can easily flow in and out through the windpipe. So that is something to keep in mind. It's something that can be scary, and it is also, I think, something that we neglect to talk about as a potential complication or part of this disease. Next slide. Sleep issues. Everybody, we ask about sleep all the time. REM behavior disorder, which is REM is rapid eye movement. Behavior disorder is seen in most patients with multiple system atrophy. It's not specific to multi-system atrophy, but it occurs in a lot of conditions where brain cells die off before they should, so neurodegenerative conditions. And what it is, typically when you're in rapid eye movement sleep, that's when you're dreaming. And when you're dreaming, your muscle tone generally is very diminished, so that you don't move at all when you dream. And just your eyes may be jerking back and forth, but the rest of you is still. In people who have REM behavior disorder, they don't have that loss of muscle tone when they're sleeping, so they can act out their dreams. They talk in their sleep, they fight, they punch. Some people come in and say, I don't sleep with my spouse anymore because they're too violent, or they're too noisy, or they knocked over the lamp, or they hit themselves. So it can be very dramatic when people have this condition. And a lot of people, if you ask them about it, they may have done this for years and years and years before they ever thought that they had to go see a neurologist or anybody about their condition. So it definitely is something is going wrong in the brain years before the actual symptoms of multiple system atrophy occur. So it's not necessarily that everybody who acts out their dreams is going to get MSA, but it sometimes is a sort of a warning that something may go wrong later on. Obstructive sleep apnea is another issue. that happens in some patients with multiple system atrophy. So some, again, the symptoms of fatigue are very non-specific. So somebody tells you that they feel tired all day long and they fall asleep when they're sitting on the couch or when they're reading, and you don't think much of it, or you think maybe it's related to your blood pressure. It could be because you're not getting a good night's sleep at night. And sometimes it's hard to know how much you're sleeping unless you actually have a sleep study and see how much you're sleeping and see how your breathing is at night. The typical person who has obstructive sleep apnea we think of as a huge person with a big neck and a big tongue, so that when they're sleeping, something obstructs their airway, blocks their airway, so they don't get enough breath. And typically when they sleep, there are periods of time when they don't breathe. So that if you're sleeping with somebody who has untreated sleep apnea, you'll notice that that's a pretty long time to go between breaths, and you're watching them, and then all of a sudden they're like, and they're making a lot of noise, and then they're back quiet again. They don't necessarily wake themselves up when they are gasping like that, and that was probably a very poor example of what that gasp sounds like, but it's a noisy extra breath. And so what they need to be treated with is something to keep their airway open, so they don't have those periods of time when their oxygen drops and they don't breathe. Because every time they have that gasp, they're going from a deeper stage of sleep into a lighter stage of sleep. It may not be enough to actually wake them up. It may wake their bed partner up for sure, but it doesn't necessarily wake them up, so that in the morning, if you say, how did you sleep last night? They may say that they slept fine, they slept the whole night through. But you need to get enough deep sleep during the night so that you feel rested, and so that you can think clearly and you can do what you need to do during the day. So that's why I think it's important for a lot of patients with these neurodegenerative conditions to get a sleep study and look at the way they're breathing at night to make sure that these things are treated, because they're not treated with medicine. They're treated with like a machine that you wear at night, and you don't want to be chasing fatigue with other medicines when you could be treating it in some more appropriate way. So that's why your doctor may recommend that you have a sleep study, even though you don't feel necessarily that you need it. And one of the symptoms of sleep apnea is excessive daytime sleepiness, that people just feel like they could fall asleep doing anything. So fall asleep eating, fall asleep driving a car, fall asleep in the middle of a conversation, and that's not normal. No matter how boring the conversation is, you shouldn't fall asleep in the middle. Other people have what's called periodic limb movements of sleep. Again, this doesn't necessarily wake up the patient, or the person who has them. It may wake up the person who's sleeping with them. But again, when they're asleep, their legs are just moving up and down, and it's disruptive. It again puts them in a lighter stage of sleep than they may otherwise be in, and so that may need to be treated as well. But all of these things, or most of these things, are diagnosed with a sleep study, and so you may need the sleep study to help make that diagnosis, because everybody says you need a good night's sleep, but I don't think any of us really realize how important that is until you haven't had a good night's sleep for a long time, and then you suddenly get it. You realize that your thinking is clearer, your mood is better, your energy is better. There's so much more stuff that you can do during the day if you have slept well than if you haven't slept well. So it's crucial to treat this, because it should be something, the sleep disorder should be a piece of this that are easily manageable. Okay, next slide. Cognitive dysfunction or cognitive function in MSA. It's interesting when you look at the sort of the criteria for diagnosis of multiple system atrophy. Cognitive dysfunction is not up there on the list of what can go wrong in MSA. We really focus on the autonomic symptoms, on the motor symptoms, but not so much on the cognitive dysfunction, because when you compare it to other syndromes that can look like Parkinson's disease, it is supposedly not as prevalent as it is in other things. Obviously, in something like Lewy body dementia, which is another synucleinopathy, there's a lot of cognitive dysfunction, a lot of hallucinations. But in multiple system atrophy, this is not a prominent feature. It should not be one of the first things that you notice in terms of symptoms. If it's going to happen, it should happen later in the course of the disease. And it's hard. Sometimes you have to differentiate problems with cognition from problems with mood. So there are mood disorders that go along with multiple system atrophy, things like depression, things like atrophy, that's going to make it seem like you're not thinking as clearly, that you're not as sharp as you were before, and that's mood related, so we have to sort that out. The slowness that we talked about in terms of the Parkinsonian variant of this can affect your thinking as well, so that somebody asks you a question and you're slower to respond. It's harder to think of the word that you want to say. It takes you a longer time to get your response out. Sometimes that response is too slow, so your speed of thinking is a little slower. If you're trying to shift from doing one thing to another, so you're trying to look up here at the slide, you're trying to look down there to take some notes, it takes you a little while to start that second process when you are shifting from another process, so that delay is much more noticeable in patients that have multiple system atrophy. There may be some frontal lobe dysfunction. Frontal lobes are very involved in planning things, so that if you have to figure out where you have to go, when do I have to turn, that kind of stuff. If I'm trying to cook and I need to figure out, I want to make chicken cordon bleu, but I have to remember to get the chicken, I have to remember to get the cheese, I have to remember where the frying pan is, so all those activities have to take place in my head before I can actually make this dinner for my family. That may be a problem, sort of paying attention, planning it all out, and I may get a little flustered in the kitchen because I can't plan that the way that I used to. Next slide. So we talked about that. There may be some problems with memory, problems thinking of what somebody just said. So if I have a conversation with you and you're telling me that what I need to get at the grocery store, and then I just try and go to the grocery store without a list, I may forget some of the things that you just told me to buy. That can be an issue in people with MSA, can be an issue for probably everybody in this room. So I don't advise going to the grocery store without a list, no matter what. There is, and when you have the list, you need to remember to look at it. There may also, so there are some differences between people who have the cerebellar variant of multiple system atrophy and the people who have the Parkinsonian variant in terms of thinking problems. Typically the people who have cerebellar dysfunction have less problems with their thinking. They may have some trouble acquiring verbal information and maintaining attention, so paying attention may be a little bit more difficult. Acquiring verbal information means that if I just tell you something and you don't read it, or you don't see it acted out, or a picture of it or something like that, it may be harder for you to get that information just from my telling it to you. So it's like if I give you verbal directions on how to get home versus if I showed you on a map how to get home. You would have a lot more trouble with my verbal directions than you would if you could follow it on the map. The people with the Parkinsonian variant have more trouble with verbal memory, more difficulty with spatial function, so they would have more trouble following the map because the spatial orientation of following the map is much more problematic for people with the Parkinsonian variant than it is with the cerebellar variant. And you may find that they don't speak as much that their verbal fluency is what that's called, is a little bit less, so that they're speaking less often. They're not saying as much as they used to say. They're just overall just talking a little bit less and less conversation. Next slide. And so I just want to sort of go to the end of this with how do we make a diagnosis. So most of what we do in the office is talk to people and examine them, and we use that to make a diagnosis of multiple system atrophy. Sometimes we send people for scans. There are scans that look at the dopamine system for people who have the Parkinsonian variant. The most recent scan is called a DAT scan. It looks at the dopamine transporter. It tells you that there is something wrong with the dopamine system, but it doesn't tell you exactly what that is. So that could be abnormal in multiple system atrophy, could be abnormal in Parkinson's disease, but it isn't specific for multiple system atrophy. So the search has been on. A lot of different laboratories, a lot of different investigators are looking at what can we do to actually make a better diagnosis. And so this is something that is relatively new, that they have found that there is some thinning of the nerve fiber layer in the retina, so in the back of the eye, and there are some specialized testing that they can do to measure the thickness of that nerve fiber layer, and that gets thinned out much faster in multiple system atrophy patients than it does in the rest of the other people who don't have multiple system atrophy. So you can look at the thickness of that layer, you can follow that over time, and that may be something that we can use to follow the progression or to help to make a diagnosis as time goes on. This testing is not available everywhere. It's not something that we routinely send patients for, but it is definitely something that everybody is searching for, to be able to have something to be able to say definitely this is for sure what's wrong with you, because typically when we see people with Parkinson's disease or Parkinson's syndromes or multiple system atrophy, you're still, when you go see even a movement disorder specialist, they're using their best guess. They're putting all of your information together, and they're examining you, they're listening to your story, they're looking at your symptoms, they're looking at any other testing that you had to make sure there's not something else causing your symptoms. And then they're telling you, yes, indeed, you have multiple system atrophy. But the only way to know that for 100% certain for sure is to look at your brain under a microscope. And we can't do that while you're using it, so that's why we search for biomarkers. That's why we look for what biomarkers are, other indicators that this is the disease, so that we could follow the progression, so that we could make a diagnosis with better certainty than just using our clinical skills. But I do want to say that part of the reason that I went into movement disorders is because I like the idea of being able to talk to people and examine them and figure out what's wrong without using a bunch of high-tech stuff, because it makes me feel good. Like, that's how medicine should be. You should take a history and you should examine people. But sometimes being as certain as you can be is not good enough. And it's also not going to be good enough if we want to do work to try and slow down the progression of the disease. And we want to start that early when the symptoms are very, very mild. We may want to follow other things. We could follow, like, your blood sugar. If we could do a blood test and we could see, yes, look, your blood sugar has come down, your blood sugar stayed down, and we can follow that over time, because clinically you're not actually going to look any different from one visit to the next. That would be very helpful in terms of assessing how well therapy works as time goes on. So we need to find good other markers of disease progression to be able to do things long term to cure this eventually, and to follow it and see if we can modify how fast it goes. I'll turn this over to Dr. Curlin, who's going to talk more about treatment and management issues, and then afterwards, both of us will be available if you have questions. Thank you.